So the examination of the abdomen consists of 4 parts: inspection, auscultation, percussion, and palpation. It is very important not to start with palpation. Palpation of the abdomen can modify the bowel signs and increase abdominal pain. So I recommend to do the palpation at the end of the examination. So inspection. Inspection means that you thoroughly look at all parts of the abdomen, and you start to look for the contour of the abdomen. Is there a symmetry? Do you see any tumors, lumps, masses, elevations? And there are different reasons for generalized abdominal swelling. So this can be the reason as a consequence of general obesity. It could be the reason that the patient has ascites due to liver cirrhosis. Also patients who have an ileus, toxic megacolon, for example, they have a distended abdomen due to air. Or if the patient has a lot of feces in the abdomen, this can also cause a general swelling. Or maybe the woman is pregnant. After that, you inspect also abdomen and look for scars. This gives you a good information about previous operations. So you can look for an open laparoscopic cholecystectomy scar, or scars as a consequence of a laparoscopic cholecystectomy. Did the patient had an appendectomy? Did the patient had a cesarean section? Or even a midline laparotomy due to a colorectal surgery. The next step is that you also look for striae. So striae are also called stretch marks in obese patients. So they are whitish, but you can also see striae in some pregnant women. So then those striae are called striae gravidarum. And some patients with Cushing syndrome can develop purple striae. Then you look also for rashes, hyperpigmentations, and of course you also have to look for a possible melanoma. Then you can look for stretch marks. So stretch marks as a consequence of itching. So patients with itching can again be those patients with liver cirrhosis, hyperbilirubinemia, or itching can be triggered by scabies. Are there signs of inflammation? Is there an abscess? Is the skin reddened? Is there an erythema? Yeah? And then you also have to look for the umbilicus. Are there any signs of inflammation? Is there an umbilical hernia? And if there's an umbilical hernia, you will further examine it with auscultation, with palpation. But now you only look. And you can also look for peristalsis. Usually you don't see any peristalsis only by inspection. But in some patients who are very slim and have a hyperperistaltic, you can see sometimes peristaltic waves, or in small children. And then you have to look for pulsations. Pulsations are usually triggered by the aorta, and in very slim patients, slight pulsations are completely normal. But in more obese patients with visible pulsations, this is usually pathologic and could be triggered by an aortic aneurysm. The next step is auscultation. Auscultation gives you important information about the motility of the bowel. It is absolutely required that it's quiet in the room, so turn off the radio or TV and make sure that you really have a quiet room to do a perfect auscultation. Before you start the auscultation, make sure that you have cleaned the stethoscope with alcohol and warm it up. Especially in winter time, it can be very cold and unpleasant for the patient. I auscultate at least at 2 different positions of the abdomen, and take your time when you do the auscultation. So I stay at one location at least 10 to 15 seconds, listening quietly to the bowel sounds. Usually I auscultate all 4 quadrants of the abdomen. So the important questions you have to answer: are there bowel sounds? And in patients with paralytic ileus, for example, you cannot hear any bowel sounds at all. Then you have to answer the question, what is the frequency of bowel sounds, if there are any? So you have to determine the frequency, and the frequency can be increased in patients with gastroenteritis and diarrhea, or it can be a reduced frequency in subileus or a paralytic ileus. Normal sounds can be described as gurgles, clicks, and there are big differences, so it depends if you just had a lunch or if you are hungry. If you are hungry, you can sometimes hear so-called borborygmi. Borborygmi are quite loud sounds of the bowel motility, and you can hear those borborygmi sometimes without a stethoscope. But you are not only listening to the bowel sounds, additionally you are auscultated also for the vessels. So sometimes you can detect bruits of the vessels. So for example, bruits when there is a stenosis of the renal artery, a stenosis of the iliac artery or femoral artery. So I want to demonstrate this. For the auscultation of a renal artery stenosis, you will position the stethoscope cranial of the umbilicus. If it is the left renal artery, it has to be located here, and you have to use a little bit more pressure to auscultate the bruits in patients with the stenosis of the renal artery. You can also listen for the iliac artery or the femoral artery. Percussion is used for the examination of the abdomen, but we also use percussion for the examination of the chest. The aim of percussion is to get important information about the underlying structure. So how much gas is in the abdomen? Does the patient have ascites? Are there enlarged organs? Or is there even a tumor? The technique of percussion was introduced by Austrian physician Leopold Auenbrugger, who was born in 1722. And he was said to be the first who used this technique. But actually it was 700 years before him. It was a Persian physician, Ibn Sina, who used the percussion for the examination of patients. Percussion needs quite a lot of training and can be practiced without a patient, on a table for example. And you are striking usually with the right hand on the middle finger of the left hand. And you are striking on the distal part of the middle finger and using the middle finger of the right hand. And I personally use often the middle finger and the fourth finger, because then I get a little bit more pressure. It is important to use always the same amount of pressure when comparing different locations of the abdomen. And I want to demonstrate it now. Hold the left hand firmly on the abdomen. Use the middle finger or the middle finger and the fourth finger and hit the distal part of the middle finger of the left hand. Different sound qualities can be found. The normal resonant sound found in the abdomen, or a dullness. A dullness can be found when you do a percussion of the liver, or if the patient has ascites or a tumor. Then there is tympany. Tympany is triggered by a lot of gas in the abdomen. So for example, a patient with ileus, or it can be found when there is a gastric air bubble. So for a normal percussion, you examine all 4 quadrants and evaluate the different qualities of the sound. So when you perform a palpation, don't start with the palpation when you do the physical examination of the abdomen, but do it at the end. Because with palpation, you can change the bowel sounds and palpation can cause pain. So before you start the palpation, make sure that you warm your hands and ask the patient where is the pain located. So if the patient tells you that the pain is located in the right lower quadrant, never start here with a palpation. To examine all 4 quadrants of the abdomen, you use a light palpation technique and a deep palpation technique. Light palpation can be performed by one hand, which I can show you here. A light palpation of all quadrants of the abdomen. Or with light palpation, you can also use 2 hands and use a rotating technique, but only light pressure. So with light palpation, you can check for tenderness if the patient has a pain while doing this light palpation, which could be a sign of peritonitis. But with light palpation, you have also the chance to detect tumors like lipomas, which are more superficially located. In peritonitis, when you are performing a light palpation, you find an involuntary rigidity of the rectus abdominis muscle. So it is impossible for the patient to relax the muscles. This is also called guarding, so increased tension of the abdominal muscles. There's also voluntary guarding, for example, when patients are nervous or anxious. So this can be overcome if you ask the patient, take a deep breath, in and out, and then you perform the light palpation. Or you can also try to distract the patient while performing a light palpation. So you speak with the patient and ask him some questions. So this is only possible if it is voluntary guarding. In a patient with peritonitis and involuntary guarding, the muscles are always tense. Deep palpation is a different technique, and it is performed with 2 hands. So you use the left hand, place it on the abdomen, and with the right hand you press the hand deep into the abdomen. And then you can also perform rotating movements. The aim of deep palpation is to identify abdominal masses like tumors in the cecum, tumors in the sigmoid, or you can also detect an enlarged organ, like a hepatomegaly, for example, by deep palpation. So deep palpation is also used for the examination of the liver, the spleen, and the kidney. So how do I perform the palpation of the liver? The palpation of the liver is very interesting for us because we can examine how large the liver is. So I will show you how I do this. I start in the right lower quadrant of the abdomen. This is important because if the patient has a hepatomegaly, you will miss the lower margin of the liver when you start directly beneath the right costal margin. So start here, deep palpation, and then go up. So with the palpation technique with the liver, I use both hands in parallel, when I'm examining the liver. And it is easier if the patient takes a deep breath while doing the deep palpation, because when the patient takes a deep breath, the liver goes down. And then I have the chance to palpate the lower margin of the liver, and I can even check if the liver is hard, in liver cirrhosis, for example, or more soft. In patients who are more obese, it can be difficult to determine the lower margin of the liver. And then there's another technique which is called the hooking technique. So I will show you now how we perform the hooking technique. I stand here and now I try to identify the lower edge of the liver. So usually the liver lies 2 to 3 centimeters beneath the costal margin. But if the patient has a COPD and emphysema, the diaphragm is located more caudally, and in those cases also the liver is lying a little bit more downwards in the abdomen. Then you can also perform the palpation of the spleen. The spleen lies more dorsally here beneath the rib cage, and you palpate the spleen with deep palpation, and you use my left hand to place it on the costovertebral angle. Use the right hand for deep palpation. And again, the patient can take a deep breath, and then I can try to identify the spleen. Usually you cannot palpate the spleen, but in a patient with splenomegaly, in a spleen which is larger than 12 centimeters and 15 or 17 or 18 centimeters, it's possible to palpate the spleen. You can also try to palpate the kidneys. Usually palpation of the kidneys is not possible, but in patients who have a kidney tumor, for example, or patients with a polycystic kidney disease, kidneys can be quite large, and in those cases you have the possibility to palpate the kidneys. So how are you doing this on the left side? Again, I take my left hand, you don't have to breathe, and I take a deep palpation, trying to identify the kidneys. On the right side, I do it in a quite similar fashion, deep palpation, and on the left side I press the kidneys anteriorly.